better? Okay. So a warm welcome to everyone here today. I'm Andrew Siegel, the Director of the Division of Long-Term Care for New York State. I'd like to welcome my team who's here today, Erin Kalickia, Alyssa Halperin, Joe Shunk, Patrick Cuccinelli, Brendan Mercado, and Francis Ness, who is diligently taking notes, and our partners in integration at CMS. Thanks to Lindsay Barnett and Melissa Seeley, Toby Oliver, Maria Barone for being here and for helping facilitate this process. Lindsay will be presenting on Medicare-Medicaid financial alignment initiative after my presentation. We also like to thank our special guests who are here today, Jim Verdier and Anne-Mary Phillips, who are here from the Integrated Care Resource Center to offer us all some information about how other states have achieved high levels of integration without a FIDA demonstration. Lastly, but not certainly least, we'd like to thank each and every one of you for being here today, all the stakeholders, the plans, the trades, and for all of you on the webinar, including other DOH staff and interagency staff, and for your participation. And we really think this is a strong demonstration of commitment to the future of integrated care in New York State. Okay. So this is our agenda for today. We do ask that you keep your questions to the end. We'll have a discussion portion, and that will be monitored by Erin Kalickia, the Bureau Director of Managed Long-Term Care, in order to get feedback and gather input from the stakeholders. So that we ask that you please hold your questions until that time. You can go to the next slide. So here you can see our DOH crystal ball. And I don't think any of us can look into our crystal ball and really know what the future holds. But I think that's why we're all here today, to have that conversation, that dialogue, and to be participatory to really ensure that going forward, everyone's input within the stakeholder community is included in the future of integrated care. And so today is really the first in a series of meetings in which we hope to begin to have the conversation on the future of integrated care in New York State and begin to envisioning what the best vehicle is available to deliver the care necessary that is both high in quality and that is cost effective moving forward. So, we are embarking upon this process because of the future of FIDA is unknown due to its nature as a time-limited demonstration, and we want to plan for the future of integrated care with enough lead time for a smooth transition for those folks who are in various products now. Again, we ask that you hold the questions to the end of the presentation. So going to the third slide here about why is integration good, right? So a lot of us have had experience, managing and coordinating the delivery of care for dual eligibles, and those are, of course, the individuals who are both eligible for Medicare and Medicaid, and that has become the central focus in a lot of ways of our state's healthcare reform effort, is to coordinate and align care for these individuals. And in many cases, the dual eligibles represent some of the most vulnerable elders confronting both economic and health challenges, and better coordination of services between the two programs of Medicare and Medicaid holds significant promise in terms of being able to improve the lives of millions of New Yorkers while achieving greater efficiency, value, and outcomes from our healthcare system. So we just wanted to do kind of a quick look here at the current landscape, for the next slide, of what we see as the current landscape of integrated care in New York State. As you all know, Medicaid redesign team made Medicaid and Medicare alignment and coordination an essential goal for New York Medicaid, and this prompted, I should say, the FIDA demonstration and the PACE and the MAP expansion. And these integrated programs boast success in a lot of different areas. We've listed some of them here, of which include individualized care planning and coordination of services, alignment and management of Medicare-Medicaid funding streams, enhancing the quality of community-based care while minimizing the need for institutional care, which is always a central focus of the work that we all do, and enhancing the value proposition by achieving better outcomes on key quality indicators such as reducing emergency department visits and repeat hospitalization admissions. And lastly, we all think about the ideals that are embedded within increasing health value and quality of life for members and individuals who are affected by these programs. So just to continue on the current landscape of integrated care in New York State theme here, we have, as I always say, 3 distinct avenues in New York State for integration, and they include FIDA, MAP, and PACE. And FIDA really, out of all the programs or products, offers the most robust service package available in New York State managed care programs. And it delivers a seamless experience for participants, which is really a key component that we've heard about, FIDA, and streamlined administrative processes on the provider side. And it provides, again, an individualized person-centered care planning process and interdisciplinary, as we call it, the IDT approach that benefits both parties, meaning participants and providers. And, you know, one of the key components, I think, of the FIDA program that we've all touted and been a part of because there's been a stakeholder process and there's been a lot of input is the flexibility that's available in FIDA that we don't have available in other programs. And so there are less restrictive requirements for plan marketing and for networks. And there's a very unique and fully integrated appeals and grievance process, which you all know about. So, you know, in many ways, FIDA achieves the most integration of the 3 programs, and it provides participation in IDT. It favors its collaborative approach that you often hear about. We also offer MAP in New York State, and MAP combines the state's standalone MLTC program with a Medicare Advantage plan to offer both long-term services and supports and Medicare acute care. And it offers care coordination through a planned care manager. So the benefit package includes MLTC benefits plus Medicare services, but does not include all the Medicaid physical health services, prescriptions, Medicaid, HCBS waiver services. So it's more limited in scope. And MAP was really one of the first attempts back in, I think it was 2000, 2007, 2008, at large-scale integration, integrated managed care, but it does provide less administrative integration than does, let's say, a FIDA or a PACE. And speaking of PACE, lastly, we have the PACE model, which was a tried and true program, which I believe started in the 70s and was adopted in New York in the 1980s, and PACE has been around for a long time. But PACE provides an individualized, person-centered care planning process, an interdisciplinary team approach that benefits participants and providers for members who are age 55 and older, or who would otherwise be in nursing homes. And it achieves high integrated service delivery, but it's different in that the Medicare and the Medicaid and the LTSS services are provided in and centered around an adult day health center. So the adult day health center is supplemented by in-home and referral services in accordance with participants' needs, and health services are provided by a healthcare team of providers, including doctors, nurses, social workers, and it really surrounds the member. And New York is really set to lead in many ways. We're proud to say the nation in PACE advancement and growth with the PACE Innovation Act and 2 new PACE centers this year. So we're very excited about that. So what is, you know, when we talk about integrated products and we think about the future of integrated programs, why is there such an emphasis on integration? And I think that really, you know, forces us to think about what the value is in integrated care, right? So I think there's universal agreement in the industry that there's tremendous value in integrating, and it's one of the less, I think, controversial concepts that I've heard support for. And the value of integration falls within a few different buckets, right? So you have the experience of care. And again, it's person-centered, you know, that's a person-centered plan and interdisciplinary team model that focuses on services to an individual's needs and preferences. And that ensures, again, a collaborative and robust person-specific approach. Then the IDT also provides data sharing, which is very important in the world we're living. You hear more about data every day, and the importance of data and knowing how to conduct interventions when you have data. So it's data sharing, collaboration, and communication across individuals, providers, and caregivers, which is important. And then care management, of course, which is a central component of a lot of our products, which takes place in a coordinated manner to specific patients' needs. And then you have comprehensive provider networks across a lot of plans that meet the broader needs of the target population. Then we have the experience of the providers, which we know has not always been ideal in FIDA, and there has been a period of which we have tried to increase the education about the program and tried to really tout some of the benefits for the experience of providers. And we see that there are several different elements to that, including having direct and continued access to the care planning and care management staff are able to participate in the process, and the providers are really involved in the planning and a holistic approach to every step in a patient's care, and that's what makes this integration very unique. Two other buckets that really highlight the value of integrated care as we see it are A, the alignment of incentives, and B, the total cost of care. So when we talk about alignment of incentives, really we're talking about emphasizing value and quality within the total cost of care model, which are beneficial to the members and providers while also creating an incentive for the plan. And these incentives provide really financial benefits that align to the quality of care. And then we have the total cost of care, which really is, integrated care helps fulfill what we all hear about, the triple aim of healthcare, right, which is to improve patient experience, to reduce costs, and to improve the health of the population. So through our dual programs, individuals are able to live safely in their homes and the communities, decreasing the higher costs associated with institutional care. And both the future of integrated care and value-based payments will be playing an increasingly supportive role as we see it in the shape of healthcare as we move forward. And as you all know, New York State right now is now embarking upon the VBP journey, if you will, as laid out in the state's VBP roadmap. And that's across all Medicaid products, and integrated programs really begin in many ways to align with the total cost of care construct, which emphasizes shared savings. And within that construct, integrated products and their respective components really emphasize better care coordination, which leads to better outcomes and better value. So we're excited to be here today with CMS, and obviously we'll continue to reach our ultimate goal, right, in fulfilling full alignment with Medicare and VBP arrangements. Which brings us to the challenges that we have of many managed care products, as from where I sit and stand in this position, in this role over the last year, which is that oftentimes an abundance of choice leads to confusion among stakeholders. And we have, because we have 3 integrated products in New York State, we often hear from stakeholders and from the community and from plans that some are favored over others, that they like the benefits of certain plans, that they think the component parts would be good to repurpose into maybe a new type of plan or a 4th plan or maybe 1 plan. So I think, really decreasing the confusion among stakeholders and participants is a key component of what we want to do moving forward. And the other thing is that we want to ensure that there's not inefficiency in the system and that we aren't duplicating efforts, because that also can lead to extra added costs and, again, confusion among stakeholders. And lastly, we think there's potential for cost shifting across payers for products that are not fully integrated, and that's really what about the financial alignment demonstrations are about, is to ensure that there isn't cost shifting and that there's one coordinated payment. So as we look to the future and we kind of try to outline from a New York State perspective what some of the overarching goals are for full integration in the planning process, I think we can agree that we want to achieve the greatest level of Medicare and Medicaid, physical, behavioral, long-term service and support integration possible while, potentially consolidating some of the programs, existing programs. So, and so as we see it, the smaller kind of sub-goals of that are to identify the platforms for integration that permit the greatest possible level of integration, and that's really a discussion. And that's why we're all here today, to have that conversation and to have that, and to jump-start it so we can continue it moving forward. And then to incorporate the best elements from New York's various existing integrated products as they exist today. We also want to offer stakeholders opportunities to help the department build what we see as the future of integrated care and the integrated care platform. And most importantly, as we think about a person-centered approach that really addresses the care of individuals, we want to ensure that there's allowed enough lead time to plan for smooth transition for individuals in the community. Obviously, safety and of individuals is always the most crucial for us. That's our #1 goal. So just to kind of map out a strategy as we move forward, I think one of the things we want to do today is to learn about valuable platforms for integrated care, and Jim Bertier is here, and he is going to offer us all some information on how other states have achieved high levels of integration. And we also want to, I think this is a learning process for all of us, and I think we recognize that as a state that, the FIDA is a demonstration. We've always said that it's a learning experience, and we should all learn from the experience and think how we can move together in a really collaborative and in a sensible fashion that really incorporates, what we've learned from some of the trials and tribulations of trying to integrate in a new program. And then I think we want to engage in a stakeholder process, right? And so that will really mean finding the best vehicle to drive one integrated care product, or two, we don't know what that is looking forward, and we really want to hear your thoughts today, and incorporating the best features of existing programs into what could be a future program for the state of New York. And then, of course, we want to, as I said already, envision what the transition process is for consolidating dual members from existing programs, if that's applicable. So, we're very excited, that you're all here to engage in this conversation, and we really look forward to hearing some of your ideas and working together. And with that, I will kick it off to Lindsay Barnett, who is going to present on the Financial Alignment Initiative. Thank you, everyone.
Thank you, Andrew, and thank you, everyone, for inviting us to be here today. We're very happy to be part of the conversation around the future of integrated care in New York. And so I wanted to spend just a few minutes talking a little bit about the Financial Alignment Initiative that we have at CMS that obviously FIDA is a part of, just to provide a little bit of context on where we are nationally with the initiative, and a little bit of what we're thinking about in terms of how to help guide this process or work with the state on this process going forward. Let's see, I think we're having a few technical issues here. While those are being worked out, I will start with just a little bit of background about our office, and hopefully the slide presentation will catch up with us in a moment. I know there are a lot of familiar faces in the audience, and many of you are probably very familiar with the Medicare-Medicaid Coordination Office and what we do, but I feel like it's always a good opportunity to take a couple of minutes to sort of say who we are and why we're here. The Medicare-Medicaid Coordination Office, also known as the Duals Office, also known as the Federal Coordinated Health Care Office, we have many names, was established by the Affordable Care Act. And the statute itself has a fairly lengthy list of things that we are asked or tasked to do. But a lot of it really boils down to trying to improve quality of care and reducing costs for beneficiaries, and improving the experience of care that individuals who receive both Medicare and Medicaid services experience. Unless we can go ahead to the next slide. So how are we doing that? Our work typically focuses in a couple of main areas. We have kind of what we call program alignment, which is really looking at Medicare and Medicaid programs as they currently exist today and thinking about how we can try to get them to work better for the 10 or 11 million people that are served by both of them. We also work a lot on developing and testing new models of integration, and obviously that's kind of the primary focus of my discussion today. But underlying all of that effort is, like I said, a desire to really try to improve the experience of care for individuals. And this slide just provides a very kind of high-level set of principles that we have been focusing on over the last 7+ years in order to try to do that. You can go to the next slide. Keep going the next one. So I wanted to talk a little bit about the Financial Alignment Initiative, which is probably the biggest of our demonstration opportunities that we currently have within the Medicare-Medicaid Coordination Office. It really is an opportunity for us at CMS to partner with states to develop and test integrated models of care for individuals. We have announced that back in 2011, and as the next slide will show, we have several different models that are kind of underneath it. We have a capitated model, which really focuses on a health plan or a Medicare-Medicaid plan, or MMP, as we call them at CMS, that is really focused on that plan being the one accountable entity that provides the full array of Medicare and Medicaid services for enrollees. The plan has entered, the plans in the different states have entered into three-way contracts with CMS and the states. And we work together very closely with the states on all things related to oversight of the plans and trying to make sure that the individuals are really receiving the care integrated care that we've envisioned. We also have a managed fee-for-service model, which is really more geared towards state Medicaid interventions. One example is a Medicaid health home, and giving those states an opportunity to share in any Medicare savings that result because of those Medicaid state interventions. It's a little bit more kind of a ACO type of approach compared to the capitated model, is sort of how I like to think about it, at least. And then outside of the Financial Alignment Initiative, technically, although we tend to lump it in as we talk about the demonstrations, is an alternative model that we currently have with the state of Minnesota that really focuses on its longstanding Minnesota Senior Health Options Program, which is a decent program that they've been running for probably 10, 15 years at this point. So the next slide focuses a little bit on some of the key components of the capitated model writ large. Obviously, each state demonstration is a little bit different, both from a target population perspective, from a service area perspective, as well as some of the care model specific. So, you know, we may have a state, they all require some type of assessment, health risk assessment, but the time frames or the mode of those assessments may be different. The individuals who are required to be part of the interdisciplinary care teams may be different. Care planning requirements may be different, things like that. Obviously, as you all well know, FIDA is unique because it is, every state is unique. FIDA is unique in a number of ways. One key thing that I like to always think about or point out is that the FIDA demonstration is the only one that we have that's really focused on the long-term care population. The majority of our other demonstrations are much broader in terms of kind of including both high long-term care needs as well as those that are kind of what we would kind of call the community WOW. Go to the next slide. Go to the next one. So this map just shows you where we are from a financial alignment perspective. We have 14 demonstrations in 13 states. 2 of those are in New York. We'll go on to the next. List them out here. You'll see we have 2 demonstrations that are the managed fee-for-service model, Washington and Colorado. The remainder are capitated model demonstrations. And as of June of 2017, we have close to about 400,000 individuals enrolled in the capitated model. We are, I would say, as you can see from the start date of the various states and various stages of implementation in each demonstration. We have some that started back in 2013, We have others like FightIDD, which just really got launched last year. Part of the demonstration process, which I'll talk about in just a minute, is an evaluation component. And initially, these demonstrations were envisioned as 3-year demonstrations. But given kind of where we are from an evaluation and data collection perspective, back in 2015, we offered all of the state participants an additional 2 years for the demonstration to allow for some additional time to be able to really see whether or not these programs are being effective. And thus far, on the capitated model side, all but one of our states have either kind of formally elected to move down that 2-year extension path or are still in discussions with us about that. That brings me to the evaluation. And I will first say that even outside of the Financial Alignment Initiative, there is a growing body of studies and evidence over the years that have showed that more integrated products tend to perform better for dual eligibles. Last year, the HHS Assistant Secretary for Planning and Evaluation, ASPE, released a longitudinal analysis of the Minnesota Senior Health Options Program, which I mentioned we are also working with in the demonstration. The findings were not specific to the demonstration, but sort of the broader program, and showed really fantastic results. 48% reduced risk of hospitalizations, less emergency department use, better access to home and community-based services. And we've seen with some of the work that MedPAC, the Medicare Payment Advisory Commission, has done over the last 4 or 5 years, that their research and analysis also shows that more integrated products tend to have better quality results and things like that. So the Financial Alignment Initiative evaluation, because this is a demonstration, we are required to have an evaluation component to look at the impact to quality of care for individuals, as well as the cost of the programs or of the demonstrations. We've contracted with RTI International to do that independent evaluation. It's kind of your typical evaluation that includes both qualitative and quantitative aspects. We are, as I alluded to a few minutes ago, in fairly early stages of getting results in. We released last fall the first annual report for our Washington fee-for-service model, as well as our Massachusetts capitated model. We expect that we'll be getting more out this year. And while at least the first couple of reports have, I think, shown some promising signs, the vast majority of what we have so far is still really descriptive in terms of analysis. And so I think it's definitely going to take us more time and data to really have a better sense of where we are from an actual kind of findings and whether or not we can say with certainty that the demonstrations are either individually or as a whole, what kind of impact they're having on quality and cost. We can move on to the next one. But just because we don't have the evaluation results, that doesn't mean we don't have a sense of some sort in terms of how things are going. Nationally, I'd say that we feel kind of cautiously optimistic. There's definitely positive momentum. First and foremost, we've seen a huge increase in the number of dual eligibles that are in fully integrated or total cost of care models. Back in 2011, before the demonstration started, there was something like 160,000 duals nationally that were in some type of integrated program, not even necessarily a fully integrated one. Fast forward to 2016, and we have over 720,000 duals in more integrated products, and a large driver of that are demonstrations, which I think is really amazing in and of itself. In addition, we have seen hundreds of thousands of people receive health risk assessments as part of the demonstrations, most of which may not have received those assessments outside of the demonstration infrastructure. We've also seen major investments both on the state and the health plan side in terms of providing care coordination, again, things that may not have happened outside of the demonstration construct. Not mentioned on the slide, I will also say that we now have, in the last year, 2 years of data for the first 5 states that started our demonstration, so those that started in 2013 and 2014, in terms of consumer experience data. So the CAP survey, for those of you who may be familiar with it, And I think we're seeing improvement in those 5 states year over year. Incremental improvement. There's certainly still opportunities for greater improvement there as well. But all of that is to say that I think kind of the things that we're seeing, even if they're not really kind of the most rigorous of quantitative analysis at this point, are making us feel good about sort of the direction that we're going. That's not to say that we haven't had challenges. I think one of the early implementation results from RTI, as well as other MedPAC and others that have been looking at the demonstrations nationally, is that integration is hard and it takes time. I mentioned the Minnesota results just in the previous slide, and while those results were fabulous and something that we can all hope that we will see through these demonstrations and other similar types of programs, it's important to remember that they've been in that business for more than 10 years and are now seeing these results. So it's something that we need to always kind of remind ourselves that this stuff takes time. And while we're seeing good progress, it's not something that we're going to necessarily kind of see results overnight. I think our other lessons learned, the early implementation findings, again, from RTI and others, reinforced some things that we kind of instinctively already knew, which was just the critical importance of engaging consumers and providers and other stakeholders as early and as often as possible. I think we certainly learned in FIDA and in other demonstrations the need to do that type of outreach and education all along the process and not take for granted that people really understand what we mean when we talk about integrated care. I have to remind myself that not everybody has been kind of working and eating and breathing this stuff for 10 years like we have or I have. And that oftentimes we need to take a step back and think about what is important for individuals, what is important for providers, and how can we make sure that we are creating that value proposition that Andrew talked about in his presentation as well. Thank you. Next slide. And so I know I've spent a lot or all of this time really talking about financial alignment from a national perspective. I'm sure you're all thinking about, but what about FIDA? We want to know what's going on with FIDA. Similar to everyone else, we still have a lot of, only preliminary information. And unfortunately, given the enrollment of a number of the plans, it sort of hindered us in being able to have some of the CAHPS data and HEDIS data and things like that just because of kind of enrollment levels that are required for this type of reporting. However, I will say that I think we similarly see some of that positive momentum, especially in the last year as we've gotten over some of the hump as the rollout and some of the changes that were made in collaboration with the state and the plans and others here in this room. I think we've seen things really stabilize. I will say that in 2016, the HRA completion rate was 97% for the FIDA plans. We see very low levels of unable to reach individuals, which is in stark comparison to some of our other demonstrations where we've seen much higher. Care plan completions and things like that also seem to be really improving. And again, that sort of positive momentum based on some of the metrics we are gathering, I think has been really encouraging. So as I said at the outset, we very much are supportive of this discussion and hope to be able to continue to be part of the process going forward. I would echo a lot of what Andrew said on his slides in terms of sort of what the goal of this process is. I think that we would certainly suggest that collectively at the state level and with all of you, it's important to think about what are those overarching goals for integration, what are the things, what are the lessons learned from FIDA or MAP or PACE or other state programs that you all think will work well for New York and for New York consumers, and focus on that, and then kind of take a step back and think about what vehicle kind of best works based on those goals and priorities. I wish I had that crystal ball that apparently DOH has. If you guys can tell me where you got it, I would love to have it. Have one of my own. So it's hard to know exactly what will be available in the coming years, but that's part of the reason why in some ways it's good to focus on sort of where do you want to go, and then think about kind of how do we then fit that into kind of what the available options are at that point in time. And then I would just say in terms of kind of opportunities for growth, I think we share the goal at DOH of trying to get as many people in, integrated, person-centered products as possible. And I would just say, I'm really excited that Jim and Anne-Mary are here from ICRC to talk a little bit about kind of different levers that other states have used to try to look at that and think about those opportunities of growth, and hope that that will at least provide a helpful roadmap of things to consider as you all and we all embark on this process. So with that, I will stop and turn things over to Jim and Anne-Mary. Thank you very much.
Hi, everyone. I'm Anne-Mary Felsh from the Integrated Care Research Center. My home organization is the Center for Healthcare Strategies. I'm here with my colleague, Jim Verdier, from Mathematica Policy Research. So we are really excited to be here, and thank you for having us. We can go on to the next slide. Sorry, we can go on to the next slide. Well, I'll just give an overview of who we are. So we are here on behalf of the Integrated Care Resource Center. We work very closely with Lindsay, Melissa, and others from the Medicare-Medicaid Coordination Office to provide support to states who are advancing integrated care, whether that be through the Financial Alignment Initiative or through other models that we'll get into in a little bit. But we work very closely with New York as well, so we're excited to be here. And I just want to point out that we do have several resources that are on our website. Please feel free to take a look at them. They may be helpful in just giving you some background or also some ideas on what other states are doing that you may be interested in. Next slide, please. So I'm going to give you a quick overview of who the dually eligible population is, Medicare-Medicaid enrollees. I think it's helpful to have a sense of what are the national statistics, what does this population look like, what are their needs, as you're planning, programs that serve this population and address their needs. I'll also give a quick overview of various integrated care options that are out there more nationally. And I know you all have several integrated care options here for dually eligible beneficiaries in New York, but I'll give you a national overview. And then I'm excited that Jim is here to give you some strategies that other states are doing when they're operating concurrent integrated programs. I know you all are very interested in hearing about that. Next slide, please. You can go one more. Thank you. So again, going over some national statistics, there are 10.5 million Medicare-Medicaid enrollees nationally. That's 1 in 5 Medicare enrollees. That's a lot. In New York State, as I think it was Andrew or Melissa mentioned, 856,000, a little more than that, dually eligible beneficiaries in New York State. Most of those beneficiaries are actually full benefit dual eligible, so they do require all Medicaid benefits. This is a faster growing demographic than the Medicare-only population. Dually eligible beneficiaries are more likely than Medicare-only or Medicaid-only enrollees to have multiple chronic physical conditions and mental health conditions as well. They also have higher increased functional limitations that require Medicaid-covered long-term services and support. So it's important to think about, when you're talking about integrated care programs, you can't not talk about long-term services and supports. This population also requires higher rates of Medicare-covered service use. And then I also just want to point out, sorry, go back to the next slide, please. I also just want to point out, when we're talking about dually eligible beneficiaries, we are talking about a very diverse population. You have the over 65 dual population as well as the under 65. And their needs could be very different. And there's a lot of under 65 dually eligible beneficiaries. About 40% of duals are under age 65 and qualified due to a disability, require increased LTSS. And more than 40% of the under age 65 dually eligible beneficiaries have a behavioral health disorder as well. Next slide, please. So with respect to the needs and costs associated with this population, this slide just shows that spending on this population is disproportionately higher than enrollment. So within both the Medicaid and the Medicare programs, spending is much higher for this population than enrollment, and there are higher costs associated with this population. And I think the spending mostly reflects the significant costs associated with a population that tends to have, as I mentioned, multiple chronic conditions and needs compared to other Medicare beneficiaries. This population is more likely to be hospitalized and in need of emergency room treatment and LTSS. Next slide, please. Sorry to grab my water. Thank you for that. So with all the vulnerabilities that are associated with this population, it's not surprising that states are trying to think through ways to better integrate care for this population, and better integrate Medicare and Medicaid services. Without integration for this population, as we mentioned, they're some of the most vulnerable enrollees that are out there among the Medicare and Medicaid programs. It's really difficult to navigate unaligned Medicare and Medicaid systems, not only across Medicare and Medicaid, but this population requires services across behavioral health, LTSS, physical health. It's hard. If your providers aren't talking to each other, it's really hard to navigate these various systems that weren't really created to talk to each other. So I know Lindsay gave a really great overview of the Financial Alignment Initiative, which is one way that states are trying to integrate Medicare and Medicaid. And I'll just say the Financial Alignment Initiative, I think it really aims to integrate on 3 pillars, the financial, clinical, and administrative pillars. And I think when we're talking about integrated care, we are talking about programs that address all 3 of those things. So we might want to keep that in mind as we continue to think through integrated care options here in New York. So as Lindsay mentioned, the Financial Alignment Initiative has 2 different models, the capitated model and the managed fee-for-service model. The capitated model really revolves around a health plan, a Medicare-Medicaid plan, or as you call them in New York, your FIDA plans, serving as the one entity that provides all Medicare and Medicaid benefits under a 3-way contract, which is unheard of. I think prior to the Financial Alignment Initiative, this opportunity wasn't there. So the financial alignment demonstrations really provide an opportunity for beneficiaries to receive all of their services in a very integrated manner from one health plan. And this, we would say, is the most integrated and coordinated option available to dually eligible beneficiaries. Next slide, please. So we talked a little bit about Medicare Advantage D-SNPs. These are MA plans that are specialized in serving beneficiaries who are dually eligible for Medicare and Medicaid. Many states have D-SNPs in place. They integrate to varying degrees with their D-SNPs. So these MA D-SNPs have contracts with the state and with CMS, and different states can require their health plans to integrate to varying degrees using these contracts, which we call MIPA contracts. I won't get into all the details. But states really have an opportunity to align their D-SNPs with their existing Medicaid plans, their Medicaid LTSS plans. So in New York, you all have your MAP program and your FIDE-SNP. So FIDE-SNP is another long acronym, Fully Integrated Dual Eligible Special Needs Plan. These are a subset of D-SNPs. Essentially, the D-SNP will apply to become a FIDE-SNP, and with CMS approval, will become a FIDE-SNP. They, based on the acuity level of their enrollees, they receive a frailty adjustment in their capitation rate. This, I would say, is a comparable option to the Financial Alignment Initiative demonstration. It's another way that states are integrating Medicare and Medicaid to a pretty high level of integration. So I'll get into an overview of who are the states that are doing this, but wanted to give you a sense of what this is if you're not familiar with the acronym. Next slide, please. So I'll quickly go over PACE. I know Andrew also gave you an overview of what PACE is and what that looks like in New York. PACE enrollees have to be age 55 or older. They must live in the service area of a PACE organization. They must be eligible for nursing home care, and they must be able to live safely in the community. And PACE is a program that I think a lot of beneficiaries enjoy. PACE becomes a sole source of services for Medicare and Medicaid for this population, you are limited in how much you can expand PACE because, as Andrew mentioned, it is site-based. That's something else to consider. We can go on to the next slide. Great. So this slide shows enrollment across integrated programs across the country. We see June 2011 on the left, June 2017, so over the past 6 years, how much enrollment has grown across these integrated care programs over the past 6 years. So the demonstrations are the newer model that's out there. The first state to enroll beneficiaries in their demonstration was Massachusetts in the capitated model in 2013. So really in 4 years, nationally, we've reached almost 400,000 enrollees in programs similar to FIDA here in New York. So New York is one of 10 states that are pursuing these capitated model demonstrations. And as I mentioned earlier, there are many states that contract with D-SNPs. Again, they contract with their D-SNPs and are able to reach varying levels of integration. So, you know, there's 41 states, DC and Puerto Rico, that have D-SNPs in place, but it's really the FIDE SNPs that are able to achieve the highest level of integration on this D-SNP platform. And then lastly, we also see that there's been, you know, an increase in PACE enrollment as well. Next slide. So this map looks kind of similar to the map that Lindsay had, but we also included states that have D-SNPs and FIDE SNPs in place. So I wanted to point out that there's a lot going on. A lot of states are pursuing integration. New York is not alone, but I do want to point out the states that are striped. New York is one of 6 states that operate both financial alignment demonstrations and D-SNPs. That's California, Texas, Illinois, Massachusetts, and New York. So Jim will get into a little bit more detail about what those states are doing as they're operating concurrent, you know, demonstrations and D-SNPs. They have different strategies for how they separate out their population, separate out service area, different contract requirements they may have. So I will turn it over to Jim, who can give you a little bit more details about those state strategies. Oh, I think I have one more slide. Sorry, one more slide. So just in New York, this is what your enrollment looks like across your integrated care program. Again, you have a lot of options, but I think it'll be helpful to hear what other states have done when they've operated multiple programs similar to New York, and how they've, you know, separated out their strategies for these different integrated care programs. Thank you.
Okay, next slide, please. And the next one after that. Okay. This slide just goes through the major integrated care challenges sort of nationally for both states and health plans. And for both the health plans and state staff, the biggest hurdle is developing expertise in Medicare, especially Medicare managed care issues, if you started out as a Medicaid plan, and all people in states don't have any particular reason to know anything about Medicare absent these demonstrations. So there's a learning curve on the Medicare side for the state staff as well. If you started out as primarily a Medicaid plan, Medicare Advantage managed care is really, really complicated. And it looks at a fairly high level a lot like Medicaid, so it's easy to be confused if you think they're the same. But they're really, really different at a lot of levels of detail beneath that. One of the benefits, in a sense, in helping you learn about this is everything in Medicare is written down somewhere. You just have to know where it is. And they have manuals that are online, and they have regulations and all sorts of stuff, and it will really answer most of your questions if you know where to look, but not so easy to do. So a steep learning curve on both sides, depending on where you start. And for the Medicare Advantage plans that primarily have sort of operational experience in Medicare, if they go into a state and work on a dual eligible demonstration, or if they're setting up a DSNP that is linked to a state Medicaid MLTSS plan, they have a steep learning curve in the Medicaid program in each of those states. Again, the state programs are very, very broadly similar at a high level, but if you look at things like how long-term supports and services, home and community-based services, state plan services like personal care assistance, nursing facilities and how they're reimbursed and what they cover and what level of care needs people have, they differ from state to state. And you can't assume if you've operated as a Medicaid plan in one state that you automatically know how to hit the ground running in another state, because you probably don't. So there's a learning curve for the Medicare Advantage plans as well. Next slide, please. So for states, the challenge is really designing programs that fit each state's sort of history and context and Medicaid and Medicare delivery systems. So you have a lot of states where there's a lot of resistance among long-term supports and services providers, nursing homes, HCBS waiver providers, to any form of managed care. And so you have to kind of work with those providers to sort of bring them along and get them to sort of work with you and understand what you're trying to do and what the benefits might be for their enrollees and for themselves in managed care. Lots of states have behavioral health services that are provided oftentimes through a different state agency, a whole different set of providers, frequently carved out or not included in managed care. So a whole separate set of behavioral health delivery systems that exist in states, and again, those have to be taken into account when you're designing one of these kinds of integrated care programs. And so you got that whole set of how do we fit it into our history kinds of issues you have to deal with. And then the next set of issues is kind of working with the health plans that you end up selecting, and however you select them through a competitive procurement or otherwise, to implement the integrated programs that are attractive enough for people to enroll in and stay enrolled in. Now, on the Medicaid side, you can mandate enrollment for dual eligibles like you can for any other Medicaid population, but you can't mandate enrollment on the Medicare side. People have the freedom to get their Medicare services from traditional fee-for-service, original Medicare. They can get it from any Medicare Advantage plan they want, not necessarily the plan that is linked to or aligned with the DSNPs that you contract with. So that's a significant challenge, a continuing challenge in all states that set up these integrated programs, including the financial alignment demonstrations, and I'll come back to a little bit more on that in a minute. The next set of challenges is just monitoring and reporting on health plan performance and quality, because that's how you build in incentives for the plans to improve over time, and you can compare plans to each other in terms of their performance and help enrollees make a decision on which plan they want to enroll in or stay enrolled in based on how they perform on these various kinds of measures that you're familiar with. The integrated care challenges for the health plans themselves, the integrated plans, once they're in place and operational, is really demonstrating to both their current enrollees and potential enrollees that an integrated plan is better for them than whatever arrangement they are currently in, whether it's original fee-for-service or some non-integrated form of Medicare. And that can be hard to do because integration is a very abstract notion. and you can tell people about, maybe extra benefits, but if they're not benefits that they perceive at that point in time that they're going to need, they're not going to give sufficient weight to them. Well, one of the things we learned from some interviews we did with integrated D-SNPs that had been operational for like 10 years or so in various states and had steadily grown their enrollment over that period of time in a purely voluntary arrangement, because these were all sort of Medicare Advantage plans. And what they uniformly told us was the single most important thing you need to do is get the enrollee linked to an individual human being who is their care coordinator, their care manager, the person who answers all of their questions, the person who helps them navigate all of the complexities of this system. And that's the single most important thing. And you need to do it within 2 or 3 weeks, because if you don't, people don't tangibly see the value of integrated care. It keeps being an abstraction to them, and it's just a whole series of sort of benefit package stuff in our handbook. And so that's a really important takeaway that we got from those plans. Plus, the other really important thing, you have to work with their providers, especially the physicians, because those are the people that people ask about what kind of a plan they should be in, or should they stay there, and if a provider doesn't like the plan, they'll encourage the enrollee to go somewhere else. So that's another really important issue that that all plans have got to deal with that are operating in this integrated environment. And then the last but most important thing is you got to deliver on the promise of integrated care. And got to have better coordination than people would otherwise get. Information exchange is absolutely critical. That's the single most important ingredient in effective integrated care, is for everybody to know what everybody else is doing or not doing. And you got to have better access and enrollee satisfaction and outcomes and all of those kinds of things. There is no secret about how to do this. Everybody kind of knows in general terms, who operates in the managed care area, how to do it. It's blocking and tackling, but it turns on how effective is your organization designed and managed, how good are the people that you've got in the plan, how good are your information systems, how easy are they to use, how much of a focus do you have on the enrollee and the quality of their care, and making the providers in your networks sort of happy and more effective and better reimbursed and less administrative hassle than otherwise. So all of those things, in theory, are easy to understand, but they're really hard to do. Next slide, please. So here's some examples of how other states, other capitated financial alignment demonstration states have dealt with the issue of the coexistence of D-SNPs and the dual demonstration. All of the capitated financial alignment states have some D-SNPs, and California and Massachusetts, New York, and Texas have the so-called fully integrated dual eligible plans, FIDA-SNPs, or they have D-SNPs that are aligned with Medicaid plans in the state, and they are what we call companion plans. But when you do that, especially if they're coexisting in the same geographic area, you have the challenge of, the state has the challenge of helping beneficiaries make meaningful and informed choices about which of those options would be better for them. And oftentimes, the two options would be operated by a managed care organization with the same name. So you've got a United FIDA-SNP, and you've got a United in the demonstration. You've got a, Anthem FIDA or Amerigroup FIDA-SNP and an American Medicaid plan. And so there's the challenge of helping people make those decisions. Then the challenge of sort of working over time with health plans and stakeholders to improve these integrated care options over time. And the states that have been doing this, kind of been in this business for a long period of time, like Arizona and Minnesota, Tennessee, and some others, they will uniformly tell you that the collaborative arrangement, arrangement between the state and the health plans is crucially important because they learn from each other and they can build increasing capacity over time in this kind of collaborative way. Now, it can't be completely kumbaya. You've got to have some performance measures and some quality measures, and you've got to compare the plans to each other. So even if they're sort of nice and friendly and cooperative, but they're not performing, you don't necessarily want to allow that situation to keep going. And then there's the issue, and I'll come back to this in a second with a couple of examples. These models, especially the Medicare part of these models, they're really complicated. And there's only so much bandwidth and staff that states have to do these things. So if you're trying to simultaneously develop a really robust so-called MIPA contract with your D-SNPs and get them linked to Medicaid plans, that's a whole set of complicated issues. Then there's another set of complicated issues that are similar but different in the demos. So that's a consideration in states that have got that arrangement. Let's go to the next slide. Can we go to the next slide? Yeah. So in general, how it works in these states is that D-SNPs and MMPs, the demonstration plans, are allowed to coexist in the same geographic area, typically, but the dually eligible beneficiaries and D-SNPs are not passively enrolled into MMPs because they're already in an integrated, coordinated arrangement they have chosen for themselves. But they can choose to disenroll from a D-SNP and get into an MMP arrangement that they consider a better fit for them or better integrated or whatever. But that's their choice to do. And states like Arizona, that I'll say a bit about in a minute, do a variety of things to encourage enrollees to choose a more integrated option, or at least make them aware of the benefits of a more integrated option. California has probably the most detailed formal policy, and it dates back to 2014, and it's on their website at the link shown there. But what they basically do is that D-SNPs that are affiliated with plans that are in their dual eligible demonstration are not allowed to enroll new enrollees who are eligible to be enrolled in the demonstration. Those people are sort of passively enrolled into the demonstration. Now, if they actually did want to go back into the D-SNP, they could do that, because you have freedom of choice in Medicare in all cases. Let's go to the next slide with a couple other examples. Massachusetts, it's not a problem, really, because the FIDA SNPs in their senior care options program, which has existed since 2004, are just people 65 and over. And the people in the demonstration are all 65 and under, so there's kind of no overlap in the populations. Illinois is an example of a state that had some of that sort of staff bandwidth issue. They're doing a demonstration, and they're also contracting with 3 D-SNPs, but they sort of had limited staff to deal with that. But more importantly, they were not able to get a lot of value out of their contract with the D-SNPs because they have kind of world's oldest MSIS, claims processing system, which really wasn't capable of making capitated Medicaid payments to these D-SNPs for anything even like beneficiary cost sharing. So they just had these D-SNPs existing in isolation with no real meaningful integration with Medicaid at all. And they just decided, we're not getting any value out of it. It's taking up time which we could better spend on our MMP. So starting next year, the 3 D-SNPs are gone, and they have their 7 MMPs. Texas is another example where the dual eligible demonstration and aligned dual eligible special needs plans aligned with their STAR Plus Medicaid Managed Long-Term Supports and Services program operate essentially in the same geographic areas. There are about 40,000 enrollees and there are 5 MMPs in mid-2017, and we also asked Texas to give us some data on how many people were enrolled in the 4 health plans they had last year that were aligned so that beneficiaries could, in theory, get both their Medicare and their Medicaid benefits from these aligned plans. And we were able to identify about 22,000 who were in that kind of aligned arrangement back then. But again, these plans, and you see their names there, they operate kind of in the same area, and the state doesn't make any particular effort to steer people one way or the other into these options. They're just kind of there. Let's go on to the next slide, a couple other examples. This is what a lot of sort of non-demonstration states have been doing, and those are the primary examples of non-demonstration states. Virginia actually has been a demonstration state, and it's going to shift to a dual eligible D-SNP platform in January of this year, primarily because the demonstration was set up to operate in only portions of the state. And subsequent to that, their legislature said, no, we want Medicaid managed long-term supports and services to be statewide. And so the only way that they were able to do that was to do what a number of these other states have done, which is to set up this new Medicaid managed long-term supports and services program and require that the plans who bid on that actually have D-SNPs or be in the process of setting D-SNPs up. And they also said, we are no longer going to contract with D-SNPs that do not have a Medicaid managed long-term supports and services plan in the state. So if, for example, you bid on this Medicaid managed long-term supports and services program and didn't win, then you got to close down your D-SNP. And these other states all do variants of that. You cannot be a D-SNP in the state unless you also operate a Medicaid plan. You can't operate a Medicaid plan unless you also have a D-SNP. And they have to be operating in the same geographic area. So people have the option of enrolling in that integrated arrangement if they want it. And there are some states, Arizona is probably the most prominent example, where they do actually do a fair amount to get people aligned or into these kinds of aligned arrangements. So enrollment is mandatory on the Medicaid side for duals. People can choose to enroll in the companion D-SNP. They can choose to enroll in fee-for-service. They can choose some other Medicare Advantage plan. And despite Arizona's best efforts, probably 55% of people choose a non-integrated arrangement. Sometimes if they are in a Medicaid plan and they sort of choose a or if they're in a D-SNP and they choose to be in a non-integrated arrangement, the state one time will put them into an integrated arrangement. But if, despite that one-time effort, the enrollee definitely wants to be in something non-integrated, then they don't bother them anymore. They let them stay in that sort of non-integrated arrangement. So they end up with about sort of 45% of dual eligibles enrolled in an aligned arrangement, and the rest of them either sort of off in Medicare fee-for-service or some other Medicare Advantage plan. So let's go to the next slide. That just lists a variety of resources that are on the ICRC website. The main one is the report on state contracting with dual eligible special needs plans that we updated in November of that year. That's got a detailed analysis of the so-called MIPA or D-SNP contracts in about 13 states, and they're the leading states in sort of this area that we've been talking about. There's also a really good data book, which is essentially national data on all aspects of dual eligibles that MedPAC and MACPAC put out. And finally, we have a technical assistance resource on just kind of the Medicare basics that we updated last month, and that's on our website as well. So a help for people who are in states or in health plans who are starting out in Medicaid and starting down the road of learning about Medicare. So that's in that resource there as well. So that's our presentation.
Okay, so the next segment we're going to enter into is going to be the no slide presentation, but I think maybe we should keep it up in case there are questions about the slides as they came up. What we would like to do for the first part of the rest of our time is take questions from anyone who has them, including the webinar. So Francis, let us know if there's any. You can type them into the text box on the webinar. For those of you there, let us know if there's any questions there. Or people in the room, just raise your hands, and I'm so glad to see hands up, because otherwise you have to listen to all my questions, and by the 10th or 12th you'll be bored. So, go ahead. We're going to need to repeat the question, I think, for the people.
Or if you want to say through the microphone. Sorry. Question on the Ohio program, the Medicare plan, with a large enrollment, and you didn't see that mentioned. I'm curious to see how they achieve that enrollment level.
Does this work? Okay, perfect. Yeah, so Ohio Medicare does have a large enrollment, and I think one of the factors that we, at least at CMS, sort of attribute some of that to is the fact that as they were rolling out the Medicare demonstration, they were also rolling out a mandatory Medicaid long-term support and service program, which they also call Medicare. So I think there was a lot of stickiness in terms of people being in a Medicaid plan and then kind of being put into the dual thing, and they were kind of already part of it. It made sense for them to be in the Medicare portion of that plan product, or it just stuck a little bit more, for lack of a technical term. But that's at least sort of what we think, because they have seen a lot more both enrollment and sort of, if you look at even the kind of penetration in terms, market penetration in terms of how many people are actually eligible and how many are enrolled, it's the highest of all of the demonstrations.
So as a little bit of follow-up to that, Lindsay or even Jim, I think some of us are probably curious about what other states are doing to enroll, whether they are passively enrolling or choosing not to, because I think in New York we have seen benefits of passive enrollment, seeing that there's a higher enrollment number, which is good usually. But on the flip side, we've seen a pitfall of a high number of opt-outs of passive enrollment. I know it's been a question for us here.
Sure. So I can say at least at the outset of the demonstration that virtually all of the demonstrations, maybe FIDA ID being the exception given its unique circumstances, had some type of passive enrollment process. Now, who was passively enrolled and on what schedule and things like that all differed from state to state. The opt-out rates that we have seen, and unfortunately it's been very difficult for us to have sort of a national kind of opt-out rate, because every state looks at the enrollment piece a little bit differently, and we don't always have like the greatest sense moving across. But it looks like sort of has varied, quite a bit from demonstration to demonstration. Overall, I think we've seen somewhere in the 30–35% opt-out rate. Some states have been much higher. Some counties in some states have been much higher, depending on kind of those circumstances. So we've definitely seen a lot of variation from state to state in terms of how the passive enrollment process went. We have, of course, there was a large wave of passive enrollment in probably the first year or so of the demonstrations as they were getting up and running. We have a number of states that do what we call kind of ongoing passive enrollment on a monthly basis, and that is generally speaking people who are newly eligible. So as people who are on Medicaid age into, becoming Medicare eligible, some states are then as they become, eligible for Medicare, putting them into an MMP, through the normal passive enrollment process with the education, all that good stuff. Some are not. So they're kind of in different, some of that has to do with sort of just the technical process, being able to identify those people early enough to be able to reach out to them and notify them before they're assigned to a Part D plan or other things like that. So there is variation in terms of kind of what is happening from a passive enrollment perspective today, even outside of the implementation process, if that makes sense.
So my question sort of follows along with this. It's directed to both DOH and CMS. But it spurred on by Jim's comments earlier about, effective care management, connections with a real person who's what they're going to do for you. And so my perspective is from the standpoint of advocacy, individual family advocacy for people that use these services, and also research evaluation. So one important thing is where can you start to say where we might go next with engaging more families and individuals right at the front end as these things are designed, because the problem obviously is high churn here, and that's, start to talk about that just so we got to. So there's a high disenrollment because people are either not given information about what doctors and other providers are in a plan, the network adequacy in a real way, or they have bad experiences, and very importantly, they don't have a care manager who has really helped them. So that's a problem in the local situation with New York. There was a lot of groups that testified for the community, office of community living, that, like blind and other specific groups, CBI, others, that were very, very concerned about losing a care manager, a case manager who was very connected with them, saw them frequently, and did very practical things to help them out. The kind of care model that is done in private managed care plans is not going to help us help this population. So the question is really about where is DOH going to go to help stakeholders get families get involved with things on the front end of the design of plans, and is CMS going to allow some slippage that was raised a year ago in Emblem and ACA's thing for the DD population. There was some mention of what health plans they want is to restrict the options to disenroll, and the length of time at which someone would be required to be enrolled in a plan once they did enroll. And there's great concerns about that process. Yeah, my name is Ralph Warren, and I'm an individual advocate. Well, we appreciate your comment and your feedback, and certainly are thinking, being very mindful of caregiver support and services in terms of thinking about how to engage families more. And, I think one of the big things that we've focused on is that Jim touched upon and others is the provider, look at the provider network for provider education so that, your physicians can inform the members more about the products available to them so they can understand how to crosswalk those services. And so we have, I think, been working very collaboratively with CMS to improve that that knowledge and to continue to think, creatively about how we can include, because the caregiver support is such a huge component of this population, right? And it's a large portion that's unaccounted for in terms of compensation, in terms of documentation, and so to better understand what the crosswalk is, I think, the department is committed to working with stakeholders and to thinking, again, as we move forward, how to work more collaboratively, and looking to see what other states have done with the demonstrations to ensure, because as you've seen from our enrollment compared to other states have been more receptive to the alignment demonstration. So I think as we move forward, that's one thing that we're going to be very mindful of.
Sure, and I will just say, in terms of, I guess, from the CMS perspective, I think in terms of engaging stakeholders of all types is something that we have always placed an emphasis on. I think from the very beginning of our financial alignment, kind of as we were seeking state proposals to participate, stakeholder engagement and involvement has been something that we have emphasized along the way. And I think certainly through kind of the early implementation, we've seen just how critical it is to make sure that we are trying to provide information about what's happening potentially in a way that makes sense. And I think that Jim's point about kind of integration as a very kind of abstract concept is a really important one. And I know that there's a lot more that we can do at the CMS side in partnership with states to try to make some of the information more understandable and accessible. As part of our ongoing, efforts around financial alignment initiative more broadly, we've really been trying to take an effort to look at beneficiary-facing materials and do testing with actual consumers and their caregivers to try to figure out, are there ways that we can, simplify and streamline some of these, many times on the Medicare side, sort of required information, but making sure that the information that is getting out there actually resonates with people in a way that they can understand. And I think we've made some progress, but certainly there's a lot more that can be done just from a kind of engaging individuals, making sure that they're aware of and understand kind of what this is, whether or not, so that they can make informed choices about whether or not it's right for them.
I'd like to also just follow up and say, when we're finished with the question and answer here, and we have plenty of time for it, I want to move into just a few minutes at the end to get a stakeholder process together. We'd like to get the input of everyone here and everybody on the phone on how frequently and where and all of that stuff. So stick around. Thank you. Go ahead.
Hi, I'm Sonia Rodriguez, and I work with the Department of the Aging, and I'm actually boots on the ground. I go out there to speak to everyone and anyone who listens to us about FIDA and what a good program FIDA is. But speaking to listening to Jeff and Evan, about the importance of the provider, I think that's absolutely key. I mean, I speak to people who said, I spoke to my doctor, he doesn't know anything about FIDA. And the trust level, we seem to them to be just some other provider or some health plan that is looking to engage them. They're very weary and leery of us when we speak to them, and they're leery about making any decisions about that important program. And so I would like to really see some kind of engagement with the provider, real engagement with the provider community, where your local doctors or your ICAs who are actually working with Medicaid people, because these are people who are actually maybe in an LTC plan, and feel, why rock the boat? I shouldn't have to move to FIDA. I'm on an LTC plan. And so those are the ones that we think we can actually carry over to FIDA and have the coordinated care that they really need and should have. And those are numbers that I think, working with Alyssa and those that, Brooklyn has a large number of those potentially eligible. We hear about potentially eligible. We'd like to know where they are in some real way through the provider community, having some interaction with the providers and say, speak to someone about FIDA, pharmacy aging, we want to have a Medicaid choice, but the providers don't have any clue. They don't know anything about it. And so I think it's really important to really start a campaign on a level where those patients actually have a trust level of who's giving them information.
Just I know there's been a request from the webinar for folks on the phone who came here. I'm going to do a very bad job of recapping what this lovely statement was. But basically, and you can feel free to jump in and correct me, but I think basically it was a really great point about the importance of engaging providers. There's a lot of providers out there who don't know what FIDA is, and that there needs to be making a more concerted effort to really target providers and help them understand so that they, being on the front lines of communication with and being trusted sources of information and communication with potential eligible individuals for FIDA, can be able to either answer their questions, know what they're talking about, or direct them to places where they can get more information. Did I do okay?
Hi, my name is Jesse Weiner, and I just want to emphasize on Ralph's point that he made. I happen to be a family member of I have a sister who's head injured, has been on the New York State CBI waiver for a long time, and thank you, that's satisfying all her needs, very happy with it. Not opposed to going to managed care at all, though. I just want to emphasize the point about getting the consumers and their families and their advocates involved, okay? We don't understand this stuff, okay? And typically our only vehicle into Albany or Department of Health is through our providers. Sometimes our messages are twisted. It doesn't get there, okay? And we really need to have a voice, okay? As you guys develop these new systems, listen to us. We probably have a lot of good ideas for you of how to cut costs, make things more efficient, because we're on the front lines every day. Okay, you're only getting the reports. Please involve the consumers and family members.
I just want to say to that, okay. Well, thank you for your comment. I just want to say that, I think we are committed at the state for continued provider education and really consumer advocacy, and we do have a lot of robust, especially for that group, for the TBI folks, stakeholder work groups to discuss that transition into managed care. But just on a higher level, I think a lot of times we have so many these CMLs out there, but it's an opportunity for folks really to write into the state, and we really do try to be as responsive as we can to questions or concerns or comments coming in. So please know that even if you're not hearing back from us, that we do collect all of those, and we do think very carefully and thoughtfully about them. So we appreciate that comment very much.
I'm Karen Wilson. I'm with Leading Age New York. We're an association of nonprofit long-term care providers, and we also include provider-sponsored managed long-term care plans. Many of our members operate D-SNP, FIDA plans, PACE programs, et cetera. And I want to build on what Ms. Rodriguez said and what Ms. Weiner said. I think one of the biggest challenges, as we all know, with FIDA has been the enrollment challenge. And one of the ways that people get connected to these types of plans is through their providers. And I think there's an important role for not just physicians to play, but also provider-sponsored managed care plans. When an organization has a face in the community and a reputation in the community, and people are accustomed to getting their care from that organization, I think provider-sponsored plans can play an important role and be an attractive option. I also wanted to mention PACE programs. I think, I appreciated what Melissa and Andrew said about PACE programs, and I think the PACE Center provides a face and a high-touch hub for long-term care in the community, but it can also be a barrier to expansion geographically, as Melissa or Andrew mentioned. So we have some ideas about how you can expand geographically using other congregate settings, like bringing medical services into social PACE centers and other settings, and we'd like to work with you on that. Because the PACE program shows some promise. And we also have seen some success with MAP and D-SNP, and I'd like to say about building on the successes of existing programs. And I think we can create integrated programs that are no more burdensome than a D-SNP program and build on that enrollment. So we look forward to working with that. And thank you very much, everyone, for convening with me. Great.
Thank you, Karen.
Hi, I'm Kate Wolf. I'm the CEO of DNA Home Care Options. We're a provider-sponsored managed long-term care plan in upstate New York. We operate in upstate only, our 48 counties, and have about 5,000 members. Just a couple things that I noted on the presentation that kind of resonated with me was some of the states with very successful demos, such as Minnesota, for example. Their demographics and their population settings are much more similar to upstate New York than New York City. New York City is unique in of its own. However, one of the frustrations being an upstate plan and provider is that we've not been allowed to participate in any of the demos. So we are, looking to be a part of FIDA. We're looking to do some different things, and we're on a timeline. And then as expansion happens, it's just trying to take what happens in downstate and put it upstate, and it's always a square peg into a round hole, and it's not. It seems to have a negative impact. In upstate New York, we have a lot of great ideas. We're very high touch and have a lot of different plans. Karen from Leading Age mentioned our plan is one that's looking into a piece model that we could maybe be more flexible. There's places in the Adirondacks where you're not going to get enough people for an adult day center, but there are other congregate settings that we could try and develop something around it if it's not cost prohibitive. So my question in all of that is, is there something we can do to include or start at least an opportunity for upstate New York to engage, especially a provider-based plan, or it's just a swift expansion and those provider-based plans upstate don't have an opportunity because bigger for-profit or larger plans are able to come in and take that part.
Thank you, Kate. We appreciate your comment. I mean, as you know, FIDA started downstate, and now we're moving into Region 2. I think we have about 3 plans there. It is a time-limited demonstration, and I think, there have been various reasons why it started downstate and kind of migrated up due to networks and certainly the density of the population, but certainly appreciate, the fact that you're a plan, provider-sponsored plan, and really bring a lot of knowledge and expertise. I think, as we think about kind of the next planning phase, I think incorporating, areas with different geographic disparities, trying to think about how to bring D-SNPs or an integrated product upstate, in a more expansive way is something we want to be very inclusive. I'll leave it to kind of others to talk about the opportunities that still exist or may exist or conversations for, FIDA upstate, but I think right now, we're on the path for Region 2. And I think, where we want this conversation to go is really think about, have your input and have others who don't have FIDA plan, or, some have exited the market. They started with a FIDA plan and kind of learn from that process to kind of build up on what's next. So I appreciate you being here today and for your feedback. I don't know if you have anything to add.
Do we have any questions on the webinar? How do we be mindful of the webinar and take 1 or 2?
It looks like there we go. It looks like there is one, this is Lindsay Burnett from CMS. It looks like there is one that came in while I was talking, and the question is about, I think, the comment around the increases in care coordination and how that's defined, sort of what we expect about that in terms of what's categorized as care coordination or whether plans have the opportunity to define that themselves. So I will say, I think if assuming I'm interpreting the point in the question correctly, what I talked about on my second to the last slide was more about the increase in the infrastructure, coordination infrastructure that has been put into place. So certainly prior to the demonstrations, we just had these plans, as many plans nationally that we're focused on full integration on the Medicare-Medicaid side and sort of the care coordination aspect being a key part of that. And it's been a lot of infrastructure, both on the state and the plan side, to really put that together. And so, that is certainly in place. And I think we, do have a sense from some of the kind of preliminary qualitative findings from RTI and others who have been looking at demonstrations in the field that, as Jim pointed out, even in the kind of non-demonstration world, when individuals are connected to a human being, a care coordinator, that care coordination works really well for them. And I think one of our goals, obviously, at CMS is demonstration to ensure, as many people who need that type of interaction and care coordination are able to access it as possible, so that as many people experience that type of success themselves. In terms of sort of what is categorized as care coordination, each of the demonstrations have pretty structured parameters as part of the demonstration. The three-way contracts I mentioned with the MMPs about kind of what care coordination requirements need to be in place. There are certainly opportunities for the plan to kind of be flexible and innovate around those different requirements, but broadly speaking, all of the demonstrations have some pretty specific and strict sort of requirements around assessments and care plan completions, and it needs to be part of the IDP and how all of that process works. And that's generally kind of all of that is wrapped up into what we think about when we talk about the care coordination aspect.
Harold.
Harold is one with Greenberg Drawing. We represent the New York Health Plan Association. Again, thank you for convening this. I think it's a good time to sort of take stock of where we've been with this program. I wanted to make just sort of several comments. First, I think the consumer engagement point is a very good one, but I will say to both EOH's and CMS's credit, there were substantial efforts at consumer outreach all along the way. I think the thing to be thinking about now is, was it effective consumer outreach, and what might you be able to do that's different? Sometimes the sort of usual efforts, especially for this kind of program, and even the usual quote-unquote consumer organization, may not be the right one. And the communications, which I think we've all felt have that sort of governmental feel to them, often because of Medicare rules and things like that, end up not really being the most way to communicate the special aspects of this program. And of course, peer-to-peer endorsements are always going to be way more effective than sort of governmental mandated communication. I think that's also very true with the provider engagement, and I completely agree with your comment about the physicians. We've heard consistently that there is a lot of physician resistance, just because, not because they don't like the idea, but just because it's new, it's different. And in some cases, frankly, it's not financially advantageous for them to have their patients be in FIDA as opposed to other programs. But sort of doing a webinar for MISNI, it's not really the way to break through that. You need to find newer, better ways to engage with providers and especially the physician community to get them to think about this differently and recognize what some of the real barriers are. And again, in some instances, they are financial, that they're going to be reimbursed better outside of FIDA than in FIDA. Which sort of brings us to the elephant in the room, which is the financial piece of it. And there was a lot of reporting, but not a whole lot on sort of how this looks financially, both to government and to the different stakeholders. And we understand there's that sort of mandated statutory savings piece with some constraints, but I think throughout this, we kept bumping into financial disconnect as to the different programs, where plans incentives may be out of line, but the same with physicians, the same with IPAs. Like, it just, for all the efforts, it doesn't really align perfectly in many cases. And sort of going back and thinking about, especially for CMS, sort of how you might deal with some of those things, I think would be helpful at really getting the pieces aligned a little bit better on the financial side. And I will say, as sort of a closing observation, that's incredibly important with the VBP initiative, okay? Because that, as the state pushes forward on that, if you think about that and the FIDA program, you know, there's the potential for real alignment. But again, to make that work well, like you can't do a good BBP arrangement for a FIDA population with a couple hundred in your class, speaking from the class. We're going to need more scale. You know, there are going to be risk issues and all these other things, but I would say that is a piece that connects all of this, but it's going to be obviously challenging as it is in all the programs. So a lot of observations there, and thank you for convening us.
That was a lot of feedback, Harold. Thank you. Well, I was only going to give the mic one. So, I mean, just quickly to touch on a few things you said, I think, you know, we're committed to find better ways to engage, you know, the provider community, and, you know, there's been some comments about how we can, you know, think about consumer engagement as well, education materials, and, yeah, the first time's not always the charm, so I think this is an opportunity, and I think this is kind of illustrative of kind of all of our committed effort, this panel and this day and this continued series of kind of thinking about what are the next steps moving forward. So this is the kind of feedback that's very helpful for us, and I think, you know, having CMS here today, Jen, and all the DOH folks really is an opportunity for us to, you know, get this feedback and digest some of it, and then think about kind of next steps going forward for possibly for next series chapter in this. But we appreciate all the feedback.
So I'll hand the mic back over to Andrew in a second. There's a question, a very similar question from an educational aspect that has come in from the phone, asking about educational campaigns that capture and share stories of people who are actually in integrated plans, and that, you know, generally it seems like there's a lot of focus on finance and the administrative side of things, and some focus on clinicians, but not so much on the general public. And are there anything that you all are planning that will be focused on, or kind of the real stories, I guess, is just the question.
The radio ad that we did was focused. It was a story of a consumer experience, and the website for FIDA has at least a dozen consumer experience stories of how they've enjoyed the integrated product, at least for FIDA. That's definitely out there in the public domain. I don't know if there are other ways that information could be shared.
I think they're asking about if we do another campaign to that. So that's great feedback.
Yeah, thank you for that question for the webinar. And I think you know, I've said this I've been here about a year now, but from the start, and coming from the provider community, coming from the plan, I think there's an opportunity. We often talk about, the financial alignment, some of the most component parts, but this is a program that, you know, while we don't have all the HEDIS and we don't have all the consumer, you know, measures at this time because it's still early on-ish in the demonstration, I think we do get a lot of stories, narratives about how, you know, the program really helps to navigate and touch people's lives, and how the person-centered model really is working and is successful. So we can think, you know, creatively about maybe how to highlight that either on our website or other ways of sharing those stories, so that, you know, we do think there's an opportunity as an individual to share, you know, some of the success stories here. So we appreciate that, and we'll definitely take that, you know, into consideration.
I just wanted to comment quickly on a couple of things that Harold mentioned. One, I think we, you know, totally agree with you that a lot of the probably very bureaucratic information that comes out of CMS is probably not the most meaningful way to engage individuals. And as I mentioned, you know, we are trying to figure out ways to do better, but there's always going to be some layer of that is part of that. And so we certainly are happy to continue to work with states and plans and others at the local level on kind of what are the more kind of local messaging that would kind of better reach actual, you know, individuals participating in the program. On the provider engagement piece, again, I totally agree. I'd be curious, though, you know, I could have said that I didn't think a webinar would necessarily be the most effective way to reach providers. But I'm curious if you all have suggestions of better ways to do that, because this is an issue, provider engagement, obviously an issue here inside of it. It's something we've also seen to various degrees of various subsets of providers in other demonstrations as well. And so if there are, better ways to actually, outreach to providers of different types to help them understand sort of what we're doing and why it may be good for their patients and consumers that they see, I think we'd be very interested in that, not only for FIDA, but also kind of more broadly as well.
Hi, Valerie Bogart with New York Legal Assistance Group. Thanks for doing this today. I think when DOH first put in the proposal for FIDA, there was a second prong that got left off, which was primary care case management, and it was not for a long-term care population. It was for people for forgetfulness and certain chronic illnesses. And I would urge that consideration be made for either changing the demo or expanding it to include some non-long-term care beneficiaries. There might be more receptivity with people who are not receiving long-term services and support, who are going to be very wedded to their primary care practitioners. They have, by definition, severe chronic conditions which they've been treated for a long time, and they're faithful to their doctors. Also, I'm really surprised that the Medicaid Advantage enrollment is still so low in New York, because I would think with the Medicaid expansion, people aging into Medicare at 65 who are already in Medicaid managed care plans, that they are going to be more receptive. Their doctors don't have to be convinced to be in managed care. They are in managed care plans, and many of those companies offer Medicaid Advantage plans. So I would think, if it's less of a lift for both the consumer education and for the provider education to be bringing them in. There's still savings to be achieved in these populations. They're still aging. They might not already be at the point where they're using those sorts of services, but they will be. And if you look at it more as a long-term shift, I think it would just be beneficial to shift some of the folks from getting else.
Hi, my name is Al Cardillo, and I'm from the State Home Care Association. We have plans and all sorts of all levels of providers within the association. I just want to follow up on the concept of alignment, and I know it's been talked about in various aspects today: clinical alignment, financial alignment. I just want to talk for a minute about procedural and regulatory alignment, and the extent to which there is a consideration within CMS about looking at the regulations and the procedures that you require when providers are responding in individual silos, to see whether those really need to be adjusted to make a system really work more fluidly when it's in an integrated system. So, for example, CMS has just adopted and actually delayed the implementation of a whole new set of conditions of participation procedurally on the home health system. That's not only going to be a very expensive proposition, and many of those things are good. I'm not debating their merit, but in the context of an integrated system, they may not all be necessarily the way you're imposing them. There are certain rules that create boundaries in a siloed environment on the use of Medicare services with a certain benefit, so would really encourage consideration of whether those could be more flexible. And I'd just like to hear your thoughts on that. Just the second piece, and you mentioned this in terms of technology and integration of information technology, which we totally agree. You can't really integrate unless you can integrate the information about the patient. But one of the big problems is most of the systems currently is struggling to develop the capacity on its own within each provider level for information development and exchange, but then that's magnified across systems, especially when you have hospitals, nursing homes, home care, health plans, all on different systems. So one thing is, what might be being contemplated to sort of help that integration process, and two, perhaps provide an ability for investment either through the rate that you pay, the integrated plan, or otherwise to enable people to really integrate and exchange care. Thank you very much.
Hopefully folks on the phone can hear the question, but if not, there was questions about kind of from the procedural regulatory side of things, whether there's any kind of ability or flexibility, I guess, to kind of take a fresh look at some of those things, particularly around, I guess, from a kind of provider perspective in particular. And then also a comment about just the recognition of the difficulties associated with the information exchange that had been discussed in Jim's presentation, especially when you're talking about a whole host of providers who have different systems that may not really be able to talk to each other. Starting with the second one first, yes, it is definitely a challenge. Agree with that. I mean, I think that certainly, in an ideal situation, all systems would talk to each other and the information exchange would flow and everything would be wonderful, and we know that that's not really reality. And, I think our hope is that we can kind of work with the plan, especially in the capitated model demonstration environment, are kind of looking at ways to try to make sure that the information is flowing, even if it's not in like the automated technology kind of way, to help with the coordination aspect. I agree with you that there's a lot more that can be done there. On the procedural and regulatory side of things, I think that we have some flexibility through the demonstration construct to kind of look at things a little bit differently, and we have probably less so in some ways on the provider side because of just the nature of the demonstration and sort of the focus on the plan as opposed to kind of going down to the providers. But it's a point well taken, and certainly something that we can be thinking about, for future opportunities as well.
If I could just follow up on that last point, I think just to illustrate. One of the difficulties is that, rightfully so, in each sort of category of service, each participant who's addressing the needs of a consumer, of a patient, has care management, case management responsibilities. How many case managers are involved in the same patient? Is any of that really coordinated? All of the participants have access to a medical record? The answer to all those questions is really no. And if we really want something to work the same way you want an orchestra to play music, we got to tune the instrument.
Yeah. No, I totally agree with that. Yeah.
Jim just has one comment about information exchange.
Yeah, actually, just a couple points on it. One is it is a major investment of dollars and resources to get these kinds of systems to talk to each other. And if you're like Kaiser Permanente, for example, you've been doing this for 7 or 8 years, and it's a totally integrated system, and you've got it all figured out. But if you're not in that category, and if you're not sort of United Healthcare that can spread those investment costs over multiple states and millions of people, then it is a challenge. And there are some states, Arizona comes to mind, where the state itself has taken sort of a major set of steps towards setting up a statewide information sort of resource that is available to sort of all of the health plans in the state, including sort of Medicaid plans and the commercial plans and others. It's still in a relatively early stage, but it's pretty ambitious, and they've got some good stuff on their website, and they've got some CMS support for doing that. But it really, for sure is a heavy lift. But if you're a state like Arizona, where you've got sort of wall-to-wall managed care in Medicaid, and you have had since like 1985, then you've got the starting point for that sort of thing. And the Medicare managed care is pretty prevalent in Arizona as well as is commercial. So you've got a number of pretty sophisticated managed care plans in the state that are essentially national organizations as well. So you've got something to really build on in making that very, very substantial investment in information technology that lets people actually exchange information in ways they couldn't otherwise.
And Jim has the microphone in his hand, or close to it. I always wanted to ask, we have heard a lot today about the challenges, which we've heard a lot about too at the department, about getting providers on board with managed care. And I particularly hear it in FIDA. I was talking to a FIDA plan earlier this week that said when they reach out to providers and they're trying to enroll them in their network so that they can get the membership, they don't say the words FIDA and they don't say the words managed care. And I cringed internally, but I was wondering whether in your work with other states, whether you have examples of ways to successfully get the providers engaged and more on board with the concept of managed care, or on the flip side of it, whether you have stories to share of unsuccessful efforts that we would want to avoid as we move forward.
I think probably the biggest point I would make is that once you've got sort of managed care implemented and you have plans in place and they are enrolling people and they have gone to the effort of setting up networks and are at the point where they've got to deliver for the enrollees and they've got to deliver sort of for the state and for their shareholders if they're publicly held, they have all the incentives and all the resources that are necessary to work with individual providers in a way that will engage those providers. And first of all, they've got to pay them at least a little bit more than they get in fee-for-service, and most sort of managed care organizations will do that. You've got to demonstrate to them that there is a benefit not only for the patients, but for the providers themselves in managed care. So again, if you've got a care coordinator or a care manager who can work with the individual physician to make sure that the person actually shows up for their appointment and that they have some kind of understanding of the information they need and the help they need from the providers so that the 10 or 15 minute visit goes more efficiently than it would otherwise. You've done as much as you can to minimize administrative hassle for the provider, but you just need to demonstrate to these providers, because you have to have them in your network, and they are the ones that are going to make the actual care that is provided to your enrollees sort of better care than they can get in fee-for-service or worse care. So that's I would say, the sort of the crucial interaction or interface or whatever you want to call it. It's between the plans and the providers in their network. And there's only so much that the state or CMS can do by sending out mailings and holding webinars and having radio ads and stuff like that. It's really got to be, again, sort of the human being interaction between the human beings in the health plans and the physicians and other providers in their networks that over time makes this work. And, it does take time. You can't persuade people that a new way of doing business is better for them just by saying it up front. You got to produce.
So, I think folks mentioned earlier today just the value of having peer-to-peer dialogue, and for a provider, I think one thing we've learned from working with other states, we've worked with MMCL on this as well. California experienced, also higher than expected opt-out rates, particularly in LA County, and one of the things they did was convene, I think it was about 400 providers, bringing primary care physicians in the room and really spotlighting physician champions, provider champions who vouched for, what the value of the program was, not only for their patients and their beneficiaries, but also for, their provider agency and provider group. So I think, and Lindsay, Melissa can probably back me up, but I think they did see value in terms of actual, increase in numbers from that convening. But at least from the conversations we've had with the state, they did see a lot of value in spotlighting those provider champions. I think there's a lot of value in bringing together peers.
last thing on this? I agree, yes. The type of provider summit that Anne-Marie talking about, I think, was helpful. And part of the, another thing that I would just mention, I also agree with Jim that a lot of it, there's only so much that CMS and state can do. But I will say that we have seen in a couple of other state demonstration scenarios, especially at the beginning, we had a couple of states where they had a lot of experience with Medicaid managed care. Providers sort of understood, especially from kind of the acute care side, managed care, more familiarity there. But the long-term support service side was brand new as the demonstrations rolled out from a managed care perspective for providers. And so in those places we saw a lot more kind of hesitancy and skepticism and concern about sort of what this would mean. And I think in a couple of places we saw fairly effectively where, very early on the state established, I think in some places it was, weekly meetings that were at the same time of, every week. They required that the plans participate in them, and providers came and sort of, asked technical questions, maybe aired some concerns, but there was plans there that the state fully expected would either answer the questions on the spot during that meeting or provide that human being interaction to be able to address those concerns. And I think over time, that ability to kind of build that trust between the providers and the plans in some ways helps. Certainly probably not going to work in every situation, but I think there were some things that, a few of the states did to try to help kind of force in some ways those conversations and engagement that did go, some way in terms of kind of building some of the trust and rapport with between some of the providers and the plans themselves. So that's just another thing that I would throw out there as another thing we've learned.
This is David Silva with the ICANN program, the Private Participant Ombudsman in New York State. And thank you, this is a really helpful presentation. I think some consumer advocates are concerned that, in New York State we have all these different kinds of plans. There are some plans I didn't even know about today. I didn't know what a 5E-SNP was. And I'm pretty sure the consumers don't know either. And that there are these different models out there that are essentially competing against each other for consumers. And I was really surprised to see actually how many consumers are enrolled in integrated products in New York State. It's just a lot of them are not in FIDA. And so it seems like now we would have a lot of data to work on kind of comparing those different models, what's working and what isn't, what are sort of which models are delivering on the different objectives about having better care management or, better integration and things like that. And, I think a lot of people might be concerned about the sort of, the idea, we're sort of by default choosing the model that has the best sort of sustainability for the plan, rather than saying, well, let's take the model that we think is the right balance of features that we want to see, and then make that the most financially sustainable for plans. Make that the best deal so that, in essence, there isn't a divestment from the model that we like into models that may not fulfill the objectives. And in connection with that, I would hope that there's, a public release of data comparing, like, okay, we've got apparently like 200,000 people enrolled in D-SNPs. Like, what's happening with them? Are they getting, is there actual coordination with Medicaid for those folks? Is there any outcome data and things like that? So we have a basis for comparison among the different models.
Thank you for your question, David. And I think, a lot of this data may not be publicly known, the HEDIS and the CORE data, and a lot of the data that is available, sometimes perhaps the consumer experience of being able to access that data isn't as, robust as we think it could be. One of the things we're looking at now in the program is how to make the long-term care programs more, the consumer experience more friendly, and this is a new initiative we're going to be kind of rolling out, and I think part of that is looking at, how people get into the system, how people become aware of what educational materials. It gets back to the consumer education and engagement and opportunities for folks, not just stakeholders, but actual consumers, to interact with the state and to have to navigate, because I think, being a member and trying to navigate the system can be very, very complicated, and as you hear about IDs and MMPs and C-SNPs and it's hard for even us to keep it straight sometimes, right? So I think, the consumer experience must be, very convoluted in some ways. So I think, you kind of resonate a lot of things that we at the state, we hear a lot of times, and I think, the idea behind looking at the consumer experience, that includes things as simple as informational brochures and, maybe their best in class practices that we can promote from a state level, and also looking at just our website, which I know, we've had a lot of feedback on how folks can read about the programs and the products on there. So I think it's something we're acutely aware of, and as we think about, we have all these products right now, but as we look to the future and think about, how are we going to tout the ones that we have, the benefits of one, I think, the idea behind having all those in New York State, we really pride ourselves on consumer choice. So I think, choice can be a good thing and choice can be a confusing thing at the same time. But I think the goal is to provide choice and also provide direction on what those benefits are so that folks, can make decisions themselves and be empowered from the consumer standpoint.
I would just make a couple points on the performance measurement front. One of them is a wonky point and another one is a simple-minded point. The wonky point is that there are not actually, in most states, really good data on what kinds of services are actually provided and not provided inside managed care organizations. They, in a lot of states, are required to report what's called encounter data, which is essentially fee-for-service data on what goes on in managed care. And states like Arizona and Tennessee and Minnesota have been requiring that for years of their Medicaid plans. Medicare Advantage just started requiring that back in 2012, and the data has been sort of submitted to CMS, but so far it has not seen the light of day. So there really is that missing measurement piece on especially the Medicare side, but in the Medicaid side in many states as well. So that's the wonky point. The simple-minded point is that if you're operating in a voluntary environment and people can enroll and disenroll in a managed care plan anytime they want for any reason, the plans that systematically enroll and keep enrolled and grow their enrollment are probably the better plans. And the ones that don't get enrollment and keep losing the enrollment that they get probably are not such good plans. And there is, in the Medicare Advantage STAR measures system, a standardized measure of voluntary disenrollment. And you can look it up and see what percentage of people voluntarily disenroll. And in the plans in states like Minnesota, it's like 1% of voluntarily disenroll. And you look at some other plans that for other reasons are probably not such good plans, and it's up around 30 or 40%. So that's telling you something pretty useful, and it's simple.
So I think we're going to have time for just one more question. Go back here before we turn to the last part of this, which is our discussion on how the stakeholder process works.
Thank you. I guess maybe this kind of is part of the transition. I'm Dan Lowenstein. I'm with DNSNY Choice. To the point about, I guess, choice and the multiple, the several products that we have here, I guess I'm trying to figure out, is the goal to get us to a single platform, call it, at the end of this process, or that does contain kind of the best of all worlds and most of, get the efficiencies from maps that are important and FIDA, and just kind of so that at the end we do have something, one thing, and that we can compete as plans on one platform, or are we going to have multiple?
Well, thank you for your question, Dan. I don't think there's any one real answer to that. I think that's the point of the stakeholder process. I think we've heard from folks, we've heard from the stakeholder community about, with FIDA, with some of the things they like about FIDA, things they like about maps, things like, thinking about things like frailty factor that some of the products have, and path enrollment. I think trying to think about, what are the good components, like grievance and appeals, what are the things that folks really care about? I think you've heard today from the panel that every state is doing this in a different way, right? And New York, obviously, is very unique. Overemphasize that in many ways in terms of what we offer. And so I think it's an opportunity here and amongst this group and the stakeholders, and I don't think you're going to hear the state telling folks what we should have. I think that's the opportunity here, is really to engage everyone, to hear from you. And so I think, we'll be talking about, next steps in terms of follow-up to this meeting, but I think that's an opportunity. You've heard from really the experts in the field here nationally and at CMS, and I think it's an opportunity for us, again, to learn from what we've done well, what some of the things that haven't gone so well with our FIDA, and to think about, next phase planning. And I think, we're doing it now because we know it's time limited, and we don't want to do this 2 years down the road or a year and a half and, be rushing towards something. And it's something certainly that folks have made outreach to the department time and time again, and they want to be involved in the process. So this is really to allow for a smooth transition if there is some sort of transition. But I think the opportunity here is for all of you to provide, further feedback here, look at things like upstate, downstate, look at including non-LTC beneficiaries. Thank you for that comment, Valerie. And then, think, about all the different component parts here. And so, I know we're almost out of time. Again, just wanted to thank all of you and everyone on the webinar, and Lindsay and Melissa and Jim and Anne Mary for being here today, and to all the DOH folks. We really appreciate the time you took today out of your work schedule to spend a couple hours discussing this, and we hope it's illustrative of kind of our commitment here to next steps and the commitment that CMS has with working with the state to be flexible in the approach here. So thank you, everyone.
So a couple of quick questions on the stakeholder process, because one thing we envisioned and have committed to is having a stakeholder process to discuss exactly those questions and questions like it that will go through the end of the year. And we'd like to get the input of people in the room and those on the webinar through the chat function on a couple of just brief things, not to decide, but just to get some sense of where the group lands on this. One of the first things I think we envisioned was convening somewhere on a regular basis to talk about these exact things. We'll circulate some agendas based on the input that we get here and based on the comments and questions that we've had today. And we'll have a series of meetings that will run through the end of the year. The first question we wanted to throw out there is, how frequently should we probably get this done? The Department of Health definitely wants to move this along in a timely fashion and stay on track. So if we met monthly through the end of the year, that might be too frequent for some, especially if they take the schedule. We could do it every 6 weeks, maybe every 8 weeks, although that would push us out a little further. Any comments, questions on it, or if we just choose? Monthly, we have the monthly. Monthly, okay. Yeah, we're loving monthly. Does anyone have any other? Okay. So if we schedule monthly meetings, we will send out some dates with agendas that'll be, probably one for September, October, November, and December, and then we'll move forward in January, hopefully. Okay. The next question is where? New York City,
Albany, alternating between the two?
Be fair for both of us.
It
Obviously, we
yeah.
all love New York City, but
We do. We do all love New York City.
Maybe we should go to Buffalo to be fair to the people in New York.
Well, that is a good point here. One of the points about alternating is that it does give people from, obviously we're not talking about just the 8 side accounts here. We're talking about the future of integrated care in New York. So if we did alternate, that's the plan we give the rest of the state.
We did have some votes for Albany.
We did.
Send out a survey with all these questions so everyone who participated.
Sure, we could do that.
Yep, we could do that.
We could do that
Get
after
it in writing.
survey after and see how the responses come in. Great. We also wanted to stage the reaction in the room too, so that's a great idea. Okay, so the next question is has to do with the focus of it. So it sounds to me like we really have 2 things to decide. One is the program design elements, which we've talked a lot about. What we've liked, what we haven't liked. Hopefully more of what we've liked about the different programs and what we want to carry forward and what really hasn't worked so much. The other is we heard Jim and Ann Mary talk a lot today about the platform upon which other states have built their integrated care models. We'd like to have a lot of good discussion about the platforms we've been using, want to try different ones. I was intrigued by the states that had both the Medicare and the Medicaid had to have both in the same geographical area. Would like to explore that a little more to see if that's something. So do we think that to explore those 2 options, we should have smaller groups that then report up to a larger group, or should we have agendas for the larger group that touch those areas in its entirety? What are the benefits of having smaller groups? Is that it's a little bit easier to convene and maybe you get more participation. One of the downsides of having smaller groups that report up to a larger group is 2 things that I've seen. One is that it is more time and more resources, and sometimes things get slowed down, and we do want to commit to doing that. And the other downside is that sometimes when those smaller group decisions get reported up to larger groups, some people feel that their voices kind of fell out of that.
Well, my suggestion, got 2 different tracks. One track for providers, okay? The other track for family members and advocates. I think you're going to get 2 different effects.
And you think that you wouldn't have the opportunity if we had all of the stakeholders in one room together to talk to each other? No, okay.
There's various factors why I think once it's done.
I think that's really agree for advocates for having separate discussions. Just because it's very helpful for advocates to hear the reasons why a plan would or would not want to do certain things, or for providers to hear why consumers want something that maybe they didn't know before. I think it's a very good opportunity for information sharing. And I would also suggest that the meeting basically start first with the design elements and then lead into the model. I think we first have to figure out what is it that we like about each program before we can make a model. And so versus having 2 concurrent separate conversations, I think we should just flow from one into the other. Oh, and I'm Crystal Scott with the Medicare.
Thank you. That makes a lot of sense. I tend to agree, but want to get. Go ahead.
Hi, my name is Margaret B. Cole. I'm at the other end of the spectrum usually. I'm pediatric. But I came here today because a lot of the problems, a lot of the concerns flow to different populations. So the design elements that you're doing here also run our lives at the other end of the spectrum for improvement. And I think you have to broaden your audience too, and it's not that all of us bring so much, it's that the impact from what is decided or what is designed here has a huge impact across the state, across all programs, across all models. And it would be a lot less confusing if everyone knew about other stuff. So I think it's really important for the provider, the advocacy, our participant, the member, whatever they're called today, can't even remember, along with the elephant in the room into these meetings, so that there's more of an imprint. We're very sequestered right now. So a lot of what was said today has impacted our whole population. Just broaden the network. How many physicians are here? How many representatives from the AMA? That's one of the issues. We're talking.
Okay, and again, this is not the stakeholder work group. We're going to.
No, I understand that, but having someone represent different populations is what's going to enrich them.
We could not have led better into my last question, the only thing keeping you from that door, which is, who is missing from this group today that we should be inviting and rolling into the stakeholder work group? So thank you for that, and you've given some good suggestions. Are there other suggestions of people that we need to roll in? We do want to get a very inclusive group of stakeholders.
I think coordinating out, like officially I'm on Long Island with developmental disabilities, but there's a lot of informal groups of various types that use those services that need to be more informed about exchanges. And I was at one meeting last night, and basically the point there is that people are not informed about the major changes going on with coordinated care, and they are interested. They feel when they find out, they feel they need to be involved. So whatever happens, it needs to go out beyond the usual suspects, beyond the organizations that are well established, do great work, that are represented here today that represent consumers, but getting more directly involved with various networks out to people that are using the service.
Seeing no other hands, and if there's no different types of comments, I think that we can call this a day. Thank you all for a really successful meeting. We'll be sending out an agenda, or a series of agendas with dates and what will be discussed at each.
Thank you, everyone on the phone.
Oh, thank you.